Hi guys, welcome to Wound Care Wednesday episode 2. My name is Laurie. If you are new here, I am a family nurse practitioner and I do wound care as a specialty. And in today's episode of Wound Care Wednesday, I am going to go over a little bit about how I come up with my treatment plans for my patients and what are the most common wounds that I am seeing in the facilities that I work in. I did episode 1 already and I talked about certification, how I even started in wound care. So if you have not seen that episode, I will link it in the cards and also in the description box so that you are caught up and up to date. Don't forget to subscribe to the channel if you have not yet subscribed already. Click your notification bell so you are notified every time I upload a video. Let's jump into this video. Now, quick disclaimer, this video is for educational purposes only. It is not a treatment plan for you or your patients in your facility. You still need to consult your wound care provider or practitioner. The most common wounds that I see in a nursing home facility, because that is where I treat patients that does have wounds, are pressure related injury, and the proper terminology now is pressure related injury. So I see pressure related injuries. I see like diabetic ulcer, vascular ulcers, as well as I do get patients who had like surgical incisions. The incision that the surgeon made dehisced, meaning it came separating apart from where they sutured it or stapled it, and that wound, say, got infected. The patient had to go back to the hospital, was on antibiotics or for whatever period of time. So those are the typical type of wounds that I deal with in a nursing home setting. Pressure related injuries are the most that I'm dealing with and that I'm seeing. Two of the biggest risk factors that affect my patients are their inability to mobilate themselves because they're bedbound, and number 2, they are incontinent. That means they sit in their own feces and urine for extended period of time, and all that moisture on their skin develop into a open pressure related injury. As well as a lot of these patients are malnourished. They have protein calorie deficits. I'm going to give you guys a quick overview of staging wounds if you are having a little bit of difficulty with doing that. So stage 1, no break in the skin. There's some redness and it's not blanchable. And blanchable mean when you push down on the skin, the blood flow comes back to the area. So it's non-blanching and there's no open area in the skin. Stage 2, skin is open and a lot of times it kind of look like it was a blister that was formed, but there is a break in the skin. Stage 3, also there's an open in the skin, but you are not seeing bone or tendon. That is how you differentiate stage 3 from stage 4, because stage 4 you are seeing bone and tendon, and also there is unable to determine or unstageable. And when I see patients a lot of the times and I see a wound that's covered with slough or covered with necrotic slough, I tend to say unable to determine or unstageable, because I do not know how deep it is, because sometimes it can be a stage 2 or it can be a stage 3, but the base of the wound is covered with slough until I order some form of treatment that will debride that off and I can see the base of the wound a little bit clearer to make a determination on the staging. Let's talk about treatment plan. So when I go and I assess a patient's wound, so my clinical decision making typically depends on 2 things for that wound. Is it draining or is it non-draining? And number 2, is the base of the wound granular or necrotic? And that is how I am going to make the decision of what treatment I should put in place for that patient. So if the wound is draining, you need a dressing that can absorb all that drainage that is coming from the wound bed. If a wound is draining heavily, I tend to use a dressing that can absorb all that drainage, because that excessive drainage will cause maceration around the wound bed, and we don't want that happening. So I will tend to order something that will absorb the drainage. Secondly, if the wound is non-draining, I will tend to order something that will bring moisture to the wound, because contrary to popular belief, you still need some moisture to the wound so the wound can heal, but we don't want any excessive copious amount of drainage. Now let's talk about granular versus necrotic. If the wound bed is granular, then I need to order something that will protect it from trauma. If the wound bed is necrotic, you can have thick necrotic eschar, look more black, or you can have thick yellow slough, and that will either need a debridement, a surgical debridement, or we can use something like a enzymatic debriding ointment until we loosen it up enough to go ahead and surgically debride the whole thing. So say for instance, I have a patient, and I have two patients, and both of them have stage 3 pressure related injury. One of the pressure ulcers is covered with yellow slough, and the other one, the base is nice and granular. For the one that has the slough, I tend to order something that will debride the slough off of the wound bed. A lot of times I will order a Duoderm. Duoderm is a autolytic debridement device. So the reason why I tend to order a Duoderm is because Duoderms are a little thicker, and Duoderms are very good barrier against patients' urine, their stool, even MRSA and Pseudomonas. Yes. So I like using Duoderm on a lot of my patients in a nursing home setting if the wounds are not excessively with necrotic eschar that needs more than just a Duoderm to help debride it out. So for the wounds that I was talking to you guys about that has like moderate drainage, I would tend to order something like a alginate. Most of the alginates that I work with come in a sheet, but they can also come in like a rope form, and that you would put on top of the wound bed because it absorbs all that drainage that is coming from the wound bed, and it's really good for partial to full thickness wound. Book wise, you guys know how nursing is in the book world versus the real world. It says that you should change these every day, but you can get away with changing these alginate dressings every other day. And you also have to put a secondary dressing to something like this. So you would order your alginate to the wound bed, and then you would order secondary dressing such as a border gauze or a Curlex wrapped if you're using it on the lower part of the leg. So that is pretty much how I come up with all my treatment plans for my patients. I didn't want this video to be too long. I will go over a little bit more details in different dressing because there's so many dressings that is out there. Comfort foams, or they call them leave-in in some places, or Mepilex. Those are highly used because number one, they are cheap, and that is pretty much the only thing I used to use when I was in the ICU. We tend to put those comfort foam right directly on the coccyx because it does help in preventing friction and shear right on that coccyx area so it doesn't open, because it also have a cushion on there. Those are good. The book wise, when I was doing my wound care stuff, says that, you know, those are ideal also for pressure related injuries. I honestly don't like them that much because I find that a lot of times when I use them by themselves and I don't have a primary dressing like one of those alginate over it, it really causes a lot of moisture in some of the patient, like more excessive moisture for some reason, and it makes the entire wound bed more macerated and around the edges really macerated, and I don't have great experience with them, but they can be used, of course, on patients, but I tend to use them a lot more if there's no opening. So if I'm just protecting a elbow, or I'm protecting a coccyx, or the malleolus, which is your ankle, and your heel, I use them a lot for that. Yes, they can be used with pressure related injuries that are open and stuff, but I don't know why every time I use them in a lot of my patients, I'm seeing a lot more maceration than I like, and I tend to kind of shy away from that. But that is it, guys. Let me know in the comments if you have any questions, and don't forget to like, comment, and subscribe, and I'll catch you up for Wound Care Wednesday episode 3. Bye, guys.